I'm very excited to introduce Dr. Norman Wolfish, who is a pediatric nephrologist. Over the course of his career, Dr. Wolfish has counseled and discussed bedwetting with many parents to help them understand the impact bedwetting can have on their child and their whole family, plus discuss their options. If you are listening to this webcast, then you've likely already realized how challenging bedwetting can be and the impact it can have on your child. There is a study, in fact, that indicates that bedwetters rate this problem as extremely important in their lives. Only parental fights and divorce were rated higher in terms of significance to a bedwetting child. With that in mind, Dr. Wolfish will share information that will help you help your child. Thank you very much for being here with us today, Dr. Wolfish. Perhaps the best place to start is with the definition. How do medical professionals define bedwetting?
Well, bedwetting is termed primary nocturnal enuresis. Primary implying that the child has never ever been dry. Nocturnal obviously meaning it occurs at night and usually not during the day. And 3, enuresis is the medical terminology for bedwetting. The Canadian Pediatric Society also adds some features to the definition. Number 1, that it should occur in a child greater than 5 years of age, and it should occur more than 2 times a week.
All right. So, do children not generally outgrow bedwetting?
By and large, children will outgrow bedwetting, but it's a very slow process. About 14% of children who bedwet will improve each year. However, there is information which leads us to believe that those children who bedwet more than 2 or 3 times when we first see them are very likely to continue on bedwetting for a fairly long period of time, perhaps into late adolescent years.
Really? So it's not true that ultimately they're going to just outgrow it?
Well, by and large, yes, they will. Unfortunately, we really don't have numbers about the number of adults who have a bedwetting problem who were bedwetters as children. What I always tell my children when I see them in the clinic is you will not walk down the aisle with a bedwetting problem. And by and large, I've been correct.
Is there any kind of family connection that parents should be aware of?
Yes, bedwetting is a genetic difficulty. And I often say to the children, don't blame yourself, blame your parents. If one parent has wet the bed when they were children, then about 50% of those children will be wet. If both parents have wet the bed, then about 80% of their children will be wet. But I also look for other features within the family milieu. For example, someone who tends to drink a lot during the day, someone who goes to the bathroom frequently during the day and has to go rather urgently, and kiddies who may be a bit damp during the day, because these are the same kind of symptoms that'll come during the nighttime, and it's only a more severe problem that this occurs. And so I look for this in all of the siblings, in the parents, and even in the first degree relatives, uncles and aunts.
What are the implications of bedwetting on the child?
That's a very important question. Bedwetting has rather severe implications to a child. They often have a great deal of shame involved in what they're doing. They're very, very embarrassed. Often parents will make them feel as if they're a bit guilty about all of this, and they have very, very low self-esteem. They don't want any of their peers to find out about it because they're concerned about being teased or being bullied. And very interestingly, many of these children have a very poor self-image. They think that they don't look as nice as some of the other kids, that they don't perform in school as well as the other kids, so that it really has a fairly major impact upon their personality.
And is there any impact on the rest of the family?
A great deal of impact, as you might imagine. Number one, it's very disruptive, especially in the morning when cleanup has to occur. It's very disruptive with fellow siblings because, number one, either they feel that the child is getting a lot of attention or there's a lot of sibling rivalry going on and a lot of teasing and sometimes bullying. So it can be very disruptive within the family.
When should a parent consult the child's doctor?
Well, that again is another good question. I usually say when the parent is concerned. However, a few caveats. It's a very common disorder under the age of 5, so I wouldn't worry about a kitty until they're over the age of 5. The older a child is, the easier they are to treat, so I tried to postpone this until the kitty is about 7 or 8. It really should occur on a fairly frequent basis, so anything more than twice a week is, again, a circumstance where the parent should be seeking medical advice from their family doctor. A child who has other kinds of symptoms, for example, discomfort or pain when they pass their urine, mentioned earlier about being thirsty and drinking a lot because we have to be concerned about some sort of structural defect in the kidney or the bladder. A kitty who goes to the bathroom frequently during the day could also have some bladder problems. So if there are some disturbing symptoms that the child has that the parent is aware of, those are the circumstances that should take them to the doctor. But probably the most important in my regard is how does the child feel about this? Do they want this to stop, and are they willing to put in the effort to try and see if they can get it to stop?
What should parents be prepared to discuss when they visit the doctor?
Well, all of the items that I had mentioned before. Number one, the occurrence. How often does it occur in a particular week or in a particular month? Does the child have any untoward symptoms like burning or discomfort or pain when they pass their urine? A lot of drinking problems, a lot of frequency problems going to the bathroom. These are very important items that the doctor would obviously want to know about. And then, of course, the family history. You know, do parents had a problem like this, or have they had any of the other sorts of problems like drinking a lot or passing their urine a lot? So those are the sorts of things that they have to be concerned about.
So the big question really is, what can be done about bedwetting?
Well, a lot and sometimes not very much, and I'll explain myself. There are many treatment programs that have been recommended, and many of them really don't have a great deal of effectiveness. But the World Health Organization and the Canadian Pediatric Society both recommend 2 major kinds of programs. One has to do with alarms, and the second has to do with medication. With regard to alarms, these are primarily sensors that will detect dampness, and they will set off an alarm. So when the child voids during the night, the alarm will go off, and the idea is that the child will wake up and go off to the bathroom. The alarm is supposed to condition the brain not to cause the bladder to empty, because the child really much prefers to be asleep rather than awake. The difficulty with the alarm is that it doesn't work well in younger children. It's usually better in older kitties, older than, say, age 10 or 12. A great deal of commitment on behalf of the child and on behalf of the family. It has to be really a family affair rather than just the child alone. Also, it's extremely disruptive. An alarm going off in the middle of the night usually wakes up the whole family, and the child sleeps right through everything. So they're the last one to get up. There is a very high failure rate with the alarm. It's only effective in about 40 to 50% of the time. It takes about 3 to 6 months to be effective, and there's a very high sort of non-commitment to the program because it is so very difficult at the very beginning. The medication that has been used is called desmopressin, or DDAVP melt. Why do they call it the melt? The melt is a thin little gelatin wafer that you place either on or under your tongue, and it melts instantaneously. Only takes about 2 or 3 seconds to melt. It requires no water, which is very helpful because it negates the necessity of taking tablets, and many of these kitties have difficulties in swallowing tablets, so they take mouthful after mouthful of water. That only fills their bladder up even more so. So this is a very, very effective compound. The other thing is it works fairly quickly and only lasts for the duration of time that the child is asleep, where some of these other medications may persist throughout the day. So that the DDAVP is one of the DDAVP melt is one of the better products that are recommended for this.
So what doesn't work?
What doesn't work? Well, again, I mentioned that there was a lot of programs that have been on the market that are really not all that effective. Many of the medications that slow down the contraction of the bladder, which are actually helpful in the elderly who have bladder problems, do not work in children. And so used by themselves or sometimes even in combination with other medications, they don't seem to be very effective. A lot of medication have been used that will change the way in which these children sleep. You don't want to interfere with children's sleep. That's the time when they grow. So you want to have these kiddies nicely sound asleep throughout the whole night, and you don't want to interfere with that. Other things like rewards, the star charts, they are basically ineffectual. And the reason often is that the child is trying to achieve something that they find very difficult or impossible, and instead of being rewarded, they are punished. So it's not a reward and punishment situation, it's a punishment situation. So I don't recommend the star charts for these kiddies. What has been recommended, and I think there's an element of controversy, is waking the child up somewhere around an hour to an hour and a half after they've gone to sleep or around the parent's bedtime. I use this technique because what I try to do is to keep that bladder as small as I possibly can throughout the night. And if you get the kitty up during that short period of time, get them into the bathroom, get them to void, and then back into bed, their bladders are now smaller again and can hold more urine. The argument is, but you're disturbing the child's sleep. These kiddies are sound asleep throughout this whole process. They don't remember a thing. It's like they're sleepwalking. So I've never ever had a concern that this is going to interfere with the child at all. So those are the techniques that I tend to use. One technique that does not work is fluid restriction, because the major problem these kiddies have is producing too much urine overnight because they don't concentrate the urine properly. If you restrict their fluids, a normal child would probably put out less urine. But these children don't concentrate the urine appropriately, so they still are putting out large quantities of urine overnight. Fluid restriction is really interpreted almost as a punishment for these kiddies, and you don't want to punish them.
Well, thank you for all of this information. Perhaps you could summarize for the parents that are listening to this what your advice is. Okay.
Number one, do not panic. This is something which eventually will disappear and go away. There's a 14% improvement rate every single year. Number two, it's a very common problem. About 15% of 5-year-olds have this, about 10% of 10-year-olds have this, and about 1% of 15-year-olds will have this. If we add up all those percentages with the different age groups, we find out there is 500,000 Canadian children who have a problem like this. So it's very common. Number three, that there is something that can be done about it, either the alarm systems or the DDAVP melt. And I think number four, and the most important thing, is maintaining the child's self-esteem. The parents have to appreciate that this is not the child's fault. It's something which eventually will mature and disappear and go away. And hopefully we have to maintain this child's sense of well-being during this period of time.
Great. Thank you very much, Dr. Wolfish.
Pleasure.